Bring it.
Okay. So we're going to be going through a PowerPoint today describing kind of a plan for a mobile integrated healthcare project here in the White Mountains. So first we'll talk a little bit about the White Mountains of Arizona, what our demographics are. We're a rural community. We respond to tribal populations, low income, retired elderly. We've got affluent vacation visitors as well. We also have an immigrant population and quite a bit of alcohol and drug dependency in our area. And then in addition to that, we have really limited access to like primary care providers, and even worse than that, going into more specialized types of medicine. So we have a really difficult medical population to work with. So anyhow, so the goals that I've set forth for this particular plan start out really slow, really small, because we wouldn't have a very big budget, and we're going to be trying to do as much as we can with the resources we currently have. Our first goal, which is really the main goal of many of the MIHs, is that we reduce hospital readmission rates. So specifically Medicare and Medicaid generally will not pay for readmission treatment of patients if it's within 30 days of them being discharged for the same type of thing. So it's really important. There's a huge cost to the hospitals and providers when these people come back over and over. Sepsis, heart failure, diabetic problems, those are really your main top three things that people get readmission rates for. So those are kind of the things that we're going to focus on in our first goal. So we're really going to be looking at right off the bat, if the hospital can help us identify individuals who are going to be a high risk for readmission, then we'd like to have an opportunity to follow up with them within 24 hours in their home, and start doing some things like in-home safety inspections, education about their medication. Anytime you can get in their home and talk to them, we're reducing the risk of them calling 911 and creating a transport. And then in addition to those particular individuals, if we have high utilization patients in our community that the hospital is able to identify, we can also start trying to do the same thing. Go in there, assess, do they have, stuff in their house that's going to be conducive to slips, trips, falls? Do they have poor lighting? Do they have multiple medication bottles that are just sitting there and they get confused? A lot of these people can be elderly, have difficulty with vision. They have a hard time, and they sometimes are on 5, 10, 20 meds. So and then to make it even more difficult, not all those meds get taken at the same time. Some are multiple times during the day. Some only have to be at night. So if we can be in there, we greatly can reduce the amount of 911 calls based off of those particular issues. So, and then also we can be a conduit for them to be able to communicate with their primary care physician. Things like telehealth. We can get in there, and if they've got issues, many times we can get on, we can patch with the hospital, we can get a hold of their primary care, and again, maybe prevent a transport. So, and again, save money for the hospital, and ultimately for us as well. A lot of these transports, we don't even get reimbursed for. They may not have insurance. So they're high risk for us. Second goal is, we want to reduce the drug and alcohol transports to the emergency department. That's a challenge that we all have in every community. We know that there's the frequent flyers, and we have no place to take them. We roll up on them, PD has called us, and they're drunk, and that's the only option. Is we can't leave them in the street. Something happens to them, then we're liable for it. So by default, we have to take them to the emergency department. That's not the appropriate place for them. That's not where we want them to be. We want to see if we can have some better options, whether it's taking them to maybe a behavioral health type of facility. If they're not really having any medical needs, if we can work with medical direction, maybe we can even get them back to their own home. You know, places that are safe, that they're going to be able to sleep it off. You know, I mean, if they have medical needs, then obviously we certainly want to take them to the emergency department. This is going to be one of the harder parts when it comes to funding, because there isn't much out there. So, you know, the goal would be to find any types of grants or like county type of health programs, ways that we can help supplement this without creating a new cost burden for everybody. And like I said, so we really need to work with medical direction to give us a little more leverage and make some other decisions. Even things like leaving people at their house. You know, we still get resistance sometimes from the hospital because maybe they're not A&O times 4. Well, we know they're not A&O times 4, they're altered, but they may not have any medical needs, and we would like to get a little bit more ability to make that assessment in the home, feel comfortable with it, and then leave them either in their own care, or hopefully if there's somebody in the house, you know, some responsible party. And then Image Trend, which is the platform we use for our PCRs, is able to go in and it'll identify areas and whatnot that we've seen over a period of time that are high risk. And if those are areas that we know that we're having lots of overdoses, we're having lots of alcohol problems, we can start focusing in those areas, maybe for some education, and also be able to get things like Narcan in people's hands when unfortunately either they or someone they know overdoses. So you know, so this one, like I said, is a little bit difficult with the financing, but there's still ways to work around it without having to spend a lot of money. And our third goal, which kind of relates back to the first one in some ways, but to increase medication compliance and in-home safety of our elderly citizens. The first place we can start with this is having our crews, when they're out running calls, do an in-home assessment, look around. Maybe it's not something that can be mitigated right then and there, but then they can come back here to prevention or whoever, and we can have a system to where we can get back in touch with them and say, hey, can we come back out? Maybe the lighting's bad and they just need help replacing light bulbs and they haven't been able to do it. Or maybe they've got some, you know, carpets that are not in great shape, you know, things like that we can help hopefully mitigate with not a whole lot of financial investment. And then same thing for the medications. When we go in these people's houses and we see them having 20 bottles of meds, that should be a clue to us to at least offer, hey, would you like us to come back and help you go through these and make sure that you're organizing them properly and that you know what you're taking and you understand why you're taking it? Because a lot of times we know when people get out of the hospital or even the doctor's office, they pick up another script. They don't even know what they're taking it for. They just know the doctor told me take it. Or they get, you hear all the time, they've got high blood pressure. And it's like, well, you know, their answer is, well, I didn't have high blood pressure before, so I quit taking the meds. Well, yeah, that's because the meds were working. So that's, you know, so these types of things where we can hopefully educate and offer those types of things, I think would be really beneficial. And again, really a low cost way of us doing some risk reduction. So, and then also some places do a pay for fee service, and you know, maybe we're able to start something where they pay $100 a month, and we come out once a week for 20-30 minutes and just follow up with them and make sure everything is kind of going smoothly. So these are types of things that again are low cost, might even be able to create a little bit of revenue or at least offset some of the cost of us sending people out, and we don't have to be hiring new people, you know, at this stage yet. So so the funding, there's multiple ways that we can get funding. You know, you want some that the seed sources, which are going to be things like your grant money, sponsorships. There's philanthropic programs out there just that are meant to help communities with things like this. And then you want your sustainable revenue. You know, I mean, we've got to, even though we can get the thing started, we've got to have some kind of income that's coming in on a regular basis like I said, if not make money, at least offset the cost to where maybe it's a net negative. So things like subscription-based programs, some insurance companies will be willing to underwrite some of that cost. Fee for service, we just talked about that. Patient contracts, things like that. And then, the hospital itself. There's a value to the hospital to not having these patients admitted and having to write off those costs. So the hospital does have skin in this game, and I think leaning on them can definitely help us generate a little bit of revenue there. So just arbitrary numbers, just looking at things like generally it's about $14,420, and this was in 2018, per patient. That was an average between Medicare, Medicaid, private, and self-pay. That's generally what that cost of readmission was. A lot of times they're writing that off. So that's a lot of money lost. So a little number, I thought, hey, $200 if the hospital would underwrite some costs here, $200 twice a week. That's $1,600 a month for a patient that we're going to be in there 2 times, 8 times through the month, most likely being able to do good work to prevent that readmission and saving the hospital, some real money. And then again, things as we get a little bit bigger, if we start needing more staffing, more equipment, there's grants out there, things like the SAFER grant, and there are lots of opportunities for that seed money. And then also hospice agencies. So something that I found when I was reading on this, a hospice agency, when they take a patient, from that point, they are responsible for all the costs of that patient. Ambulance, food, medication. So whatever they're earning a month on that patient, they have to cover everything. So if we're transporting an ambulance, that can take a pretty good chunk out of that hospice's funds for that individual patient. So working with hospice to do kind of the same type thing. Maybe it's fee for service. Maybe it's identifying those high-risk patients that they know are going to be coming in and out with things like sepsis, the MRSA patient, all that. So I mean, it's beneficial for that organization. I think it's a good place to start looking for some money. And then commercial insurance billing options, things like incentives, and again, every time we don't transport these patients, somebody is saving money, whether it's the patient themselves, whether it's their insurance, whether it's Medicare, Medicaid, whether it's the hospital having to write off a fee, whether it's us having to write off a fee. When we transport in district, if they're a taxpayer, anything that doesn't get covered by insurance or whatnot, we write off that difference. That's not great for us, obviously. So the goal is really to just reduce those transports that are unnecessary. And then there's things like EMS loyalty programs, that it's not just about not transporting them. Sometimes it's putting a plan together for this patient, finding out, okay, what is generally the reason you're going to the hospital? Okay, how do we start mitigating those things? Is it that your medications, you keep running out of medications and you don't know why? Is a family member stealing them and selling them? You see it all the time. So read a couple situations where all they did, EMS was able to help them get a safe for $230. They kept their meds in there. No family member was stealing them anymore. And that reduced the transports by like 60% for that patient.
Wow.
Yeah, so I mean, there's some of these things are such small ways to really mitigate some of these costs. And then, we have to collaborate with everybody around. This isn't meant to be a competitive type of endeavor. We're not here trying to take money from, hospice or EMS, or the hospital, the ED. The goal here is to work as a group, collaborate, to find options, and be creative, like in the funding options, resource allotment, and just make sure that everybody, all the stakeholders in all of this, know that we're not trying to take business, because pretty much all of these companies are for profit. So, we want to make sure that we meet that head on in the very beginning, so that we don't have, you know, that kind of resistance. So, so ultimately, what my projected outcomes, what I would like to see out of this in the initial stage, this kind of recaps that $14,000 rough cost of readmission. If we could just simply reduce readmission rates by 25%. So let's just say that we eliminate 10 readmissions a month at Summit. That's roughly $140,000 a month that they're going to save. So, you know, it starts adding up. And so that's why I say that there's a vested interest and a financial interest from the hospital to work with an MIH program and try to mitigate those things.
Yeah. So if you had, let's say for instance, we have a for-profit hospital like you identified earlier. If we were to commercial contract with them, was that something you?
That's kind of I'd like to see, have something of that sort. Like, hey, you give us your high-risk patients, we'll charge whatever fee. I picked, you know, $200 twice a week, you know, but whatever fee seems appropriate, you know, we've got to evaluate what our true cost is to run that call.
Yeah.
But yeah, contract with them to, hey, we're going to go out and check on them because whatever you're putting in, maybe that's $1,600, maybe $2,000 a month into that patient, we're saving you $14,000, possibly even more. They might go, some of these people get readmitted, we transport them 3 times in a week.
Yeah.
You know, so I mean, it could be even more than that. So, so yeah, that's exactly kind of where my head's at for that. And then obviously reducing drug and alcohol related transports. So, you know, those are a burden, especially for a smaller EMS system like we have, because as we know, you know, you have 5 ambulances going up here, and now we're taxed. We've got nothing to go to respond with, or the response is going to be really far from 20 miles away at the other end of Sholo. So if we can free up the system, that leaves us more available for those more high-risk, high-acuity calls that really, truly do need transport and our response. So, and then also providing more appropriate destinations for these patients. You know, it's not just about saving money, it's about, the ER isn't the right place for them most of the time. We're not doing the ER, we're not doing the patient, we're not doing anybody in service, there's just no other place to take them. So, so if we can start to identify a place that would be more appropriate, I think, you know, that would be good for the patient as well. And then obviously, it gives us opportunities to, if we're working with them in a non-emergency room environment, we can have more opportunities to talk about things like rehab and ways to help them get through, you know, this addiction or whatever problems they're going through. So it can be a lot more personal. And then again, like I said earlier, really identify target areas and demographics that we can put some effort and some extra time and resources into, whether it's, like I said, Narcan, or just getting out there and talking to some of these folks, you know, so anyhow, those are the goals that I'd like to see. And none of these things up there really cost any money. You know, they're not high cost. So, and then our last goal, you know, increase medication compliance and in-home safety. So, you know, reduce those 911 calls due to med errors or confusion or people's just general paranoia and concern about, you know, what's going on. Reduce those in-home injuries, so those slips, trips, and falls. That's going to reduce those 911 calls and unnecessary trips to the hospital. It'll build trust and confidence with the public when they know that we're out there, we're really trying to help mitigate the situation. We're not just there to show up, transport, and drop you off. That not only builds trust and confidence with the public for our one response, but over time, things like bond initiatives and things like that. So, you know, so I mean, it's a really good way to keep our name looking good in the community. And then again, providing that value-based service to our community members. You know, if they know they're getting something out of even like a fee-for-service type of thing, they're going to be a lot more. They're going to be happier and they're going to be healthier. So, anyhow, that's kind of my plan for just a real small startup mobile integrated healthcare plan for our area. You guys have any questions?
Do you feel like using like a vehicle like for further cost savings, integrating the unique community risk reduction things we have here, like wildland urban interface, and medical's obviously 2 great risks. we face integrating those two with like a low acuity vehicle crew staffed out of like a brush truck.
Absolutely. Yeah, I mean, we have command trucks. My vision would be certainly in that initial stage, those patients that we're showing up to, that high risk, high acuity, 30-day type of readmission. I wouldn't particularly want to go check on them in an ambulance and tie up that ambulance.
Right.
We could send a paramedic and an EMT, or even just 2 EMTs in the beginning, just to start out and check, because we're just checking on them at first, right? It's not a 911 situation. So yeah, something like a command truck, a brush truck, something like that, to where we're not tying up one of our main out rescues for an IFT, or because I foresee them being busy through the day. And that's the only challenge that I see in the very beginning, is that staffing part, right? Do we have 2 extra people on shift that can be out doing that? A lot of times, if we're just at par, we're not going to be able to do that. So, as I work through the kind of the kinks of this, that is one of the bigger challenges that I see, is how do we staff it to where we can provide the service on a regular basis, consistently, and regularly. So, anything else? No? Cool. Thanks, guys. I appreciate you letting me talk to you.
Thank you. I was unaware the hospital